The robotic approach for the donors involves making 5 8-millimeter incisions across the abdomen at the level of the umbilicus. This allows us to place our trocars, our instruments, our camera, and do everything we do open. For example, we could dissect the blood vessels, the bile duct, mobilize the liver, and then divide the liver. When we're ready to take the liver out, we make a fan and steel incision that does not involve any muscle division. We just spread the muscles open and allows us to take the segment of the liver out. For the recipients, the approach would be very similar, and the incisions are made in the same way, although because of the disease process and the size of the liver, we're a little more restricted in who we could apply this procedure to. I think that any person that comes forward to be a donor is appropriate for the robotic approach. Since we started the program, all the donors that have been robotic. As a matter of fact, it even allowed us to extend the criteria, such as higher BMI, because we're still able to do this with small incisions. For the recipients, we're still limited by how sick they are, how big the liver is, so we're a lot more selective in who can get this robotic approach. Well, this operation is relatively new, so there's not a lot of data out there to show the difference between the open and the robotic approach. But from our experience and our preliminary data, we've seen quicker recovery, we've seen fewer infections, we've seen fewer hernias, and overall, I think this approach is beneficial to the donors. There's no question that there's a learning curve associated with a robotic approach. Initially, it did take us longer to do the surgery, but since we've been doing it for over a year, and as we've accumulated experience, our timing is about the same now. The biggest advantage is in the perioperative time. Since we're not making a big incision, we don't need an epidural. The epidural had its drawbacks, and it prolonged recovery. And since we're not doing the epidural anymore, the recovery is quicker, and this allows the patients to get home sooner. I think there are advantages for specific populations. For example, when we make the big incision, one of the most frequent complications is wound infections. And the higher BMI patients, the higher risk of wound infection. Since we're not making big incisions, now we're considering higher BMI donors for this procedure because of the robotic approach. I think the robotic approach shouldn't change how referring physicians refer patients. They should refer the patients whether we could do robotically or open, and we will be the ones deciding who would be a good candidate for the robotic approach. As I said before, all donors now are appropriate and good candidates for robotic approach. On the recipient end, we're still very limited by how sick the patients are and how big the livers are. For patients with advanced liver disease, they should all be referred for transplantation, whether we do this robotically or not. There will be some patients that have small livers or not very advanced in their disease, and we could attempt it robotically, but they should all be referred. Now for the donors, since we've been doing them all robotically, every single donor is considered an appropriate robotic candidate.